We cannot hear you, sir. You are muted.
I think you can hear me now, okay?
Yes, sir.
Today, my topic is the volumetric modulated arc therapy, VMAT of head and neck cancer. I am now working as a senior medical physicist in Department of Radiation Oncology, AKUH. This is my disclosure statement. And what I would like to cover today is the little bit introduction of the VMAT. I'm sure that all of you are familiar with now the concept of VMAT and the basic idea. Then some history about the VMAT, how it came into being. And then we have some optimization methods of the VMAT, where we will cover some topics regarding the contouring for medical physicists, then the arc arrangement and the optimization process, and the last plan evaluation. Then we'll switch to the Eclipse, our Eclipse workstation. There we will see basic plans of the VMAT of the head and neck cancer, 2 plans, and then the portal dosimetry image. So VMAT is just the type of IMRT where only 3 parameters are modulated simultaneously. Before that, they were not included in IMRT. Now we have the gantry speed, dose rate, along with the leaf speed. Formerly, it was termed as IMAT, intensity modulated arc therapy, which was described by Dr. Cedric Yu in 1995 in his paper, where in IMAT, we have the limitations of the dose rate, which was remained constant during the rotation of the gantry. It was termed as first generation till 2007, when before they introduced a dose rate in the IMAT. Then the next generation came into being since 2007, where we have introduced a dose rate with the variation with the rotation of the gantry. Another thing which we met in 2007, Mr. Carr Otto introduced on the basis of his goal, which was that it was time efficient, along with the capable of producing high conformal dose distribution with the arc's 360 degree rotations and the improved accuracy with the high sampling of beams. And then the recognized rep planning must be passed for the plan adaptation. So after the introduction, a little bit introduction and the history, we are now switching to the VMAT optimization method. There are a lot of methods, and I am here just sharing the experiences which we are experiencing since for the last year, since 2020, when we have started the VMAT in AKUH. So there are some portions which are very necessary before the optimizations. One part is the contouring, which is the basic part of the VMAT, although it is also basic for the IMRT plans, then also for the VMAT plans. Then we have the arc arrangements and the optimization process and the plan evaluations. Contouring is very much important because it is whenever you use the plans for IMRT or VMAT, it is directly linked by the treatment planning algorithm. So near the structures, we should have the perfect contouring, although we can compromise if the normal structures are away from our targeted structures or they are not in the beam. So it will be very helpful that if we contour the organs beautifully for taking demand optimization algorithm. So we have to basically, if the doctors are here, so they should be very careful regarding contouring if they are switching to the VMAT or the IMRT plans. So this is the medical physics contours. So I'm hopeful that my dear medical physicists, you will not be scared of this heading medical physics contours. There's a little bit of work which should be included, but what is medical physics contour? The planner often defines the additional structures, except target and OARs, which are primarily contoured by the physician or the residents, and which is used in the optimization. So except that the target and the OARs, we have some other structures which are used in the VMAT optimization. They can be said as medical physics contours. These optimization only structures are just the expansion of OARs and possibly the combination of target and the normal tissues. It is really helpful in when we optimize the plan and we have the different prescription doses and the dose gradient and the dose fall of outside the PTV. These are some general guidelines for contouring. And these are the RTOG foundations, and then we have the double APM task group 263, which also supports the medical physics contouring or the normal OARs, which we have to contour. Medical physicists have to contour before the optimization. So contouring is basically OAR plus margins. We have to contour the OARs and then we have to create some margins so that there should not be high adjacent dose with the tumor. For example, if we have optic chiasm, optic nerves, brainstem, lenses, or cochlea, so we have to give the margin of 3 millimeter, a uniform margin of 3 millimeters for the PRVs. And if we have the spinal cord, then we have to create a 5 millimeter uniform margin for the PRV. There are a little bit confusion regarding the spinal cord and spinal canal. For this is the 5 millimeter margin is for the spinal cord, not for the spinal canal. For contouring, if you are establishing a list of contouring over there for optimization, then you have to identify them easily so that it should not be mixed with the normal contours by the doctors. Like introduce the Z number before the nomenclature so that it should be all listed at the bottom of the contouring mode. The Z number is also recommended in the double APM TG262, where it should not create any difficulty for you or for the physician to see the contouring list. This is an example of the OARs with the margins, like the optic nerves. They have given the margin of 3 millimeters and also the brainstem, where the basic margin is OAR plus 3 millimeter. So what are the optimization only structures? We have the PTV, the final PTV. Then we have the OAR contours and structures, some of the extra structures which are on need. And then we have the overlapping PTV and the normal tissue. The contourings like that by the physician that the PTV and the normal structures are merged in each other. So what we have to do, we have to introduce another PTV so that we have a better optimization for that. Then we have rings and the edges, which would be later described in the slides. Why we are contouring these OARs marginal structure? Because when we have to see the dose structure, like for the optics and the brainstems and the cord, for evaluation, we see the maximum dose which is given to these normal structures. And for the other regions, we can see that the carotids and cochlea receive the mean dose which we evaluate after the planning. This is the example of the overlapping structure where PTV and brainstem. The red is the PTV contoured by the physician, which is merged with the yellow color brainstem. And later on, it was VMAT PTV was introduced with the green color so that we can have the better optimization and we can limit the dose which is the structure overlapping in the normal organ. Then we have rings. Rings are just the bands which are surrounded around the PTV. They have the thickness, normally they have thickness around 1 centimeter, or it can be around 1.5 centimeter. And they are just 3 millimeter away from the PTV, following the rule that the 5% per millimeter dose fall from the PTV, and 3 millimeter margin should be introduced so that we have the 85% blockage of the dose from the PTV. Then we have edges which are used for the optimization. Edges are basically the rings, the band inside the PTV. When we use the algorithm for the normal structure, so there are some chances of the dose misses, the less coverage of the PTV at the edges. So we have to introduce this edge so that it is helpful for algorithm to focus on that area more efficiently. Sometimes we introduce corners. again, like the edges, if we have very high constraints for the OARs, and we are missing the coverage of the PTV. So we have to introduce the corners at the end of the PTV on the cover, as you can see in the picture with the magenta color. So what will they will cover with the, we have to introduce a priority for that, and they will cover the PTV so that we can have the better coverage. Also in the other contours, we can use the hotspot structures or the cold spot structures for the optimizations. When you have a perfect contouring means that it's a very good contouring by the physician along with the medical physics contours are included. Then we have to select the beam arrangement. So our beam arrangement or the arc arrangement for the VMAT plans is very much necessary, because it plays a very important part in a good plan. It is dependent on the anatomical site specific, because some different regions have different types of arrangements. So when VMAT, a good thing is that we have more degrees of freedom. Like an IMRT, we have a fixed beams, but in VMAT we have more degrees of freedom. So we have to think about the arc arrangements as well. It would be helpful also in the optimization algorithm. Then we have to select that arcs which should be, there should be a beam clearance. Like sometimes we can introduce the non-coplanar arcs in the brain plans, but we have to check all the possible clearance for that. How much arcs we can introduce, it is dependent on the PTV size, also the location and the OARs, at how much priorities we are defining. Remember that if you are planning for the head and neck tumors, so avoid entering through eyes or lenses, although exit may be allowed with the appropriate constraints. For selection of two arcs, if you are using the two arcs with the counterclockwise and clockwise direction, the counterclockwise direction, so it's a recommendation that don't use the same collimator for that, because there are very much possibility of generating the same fluence for both these arcs. So always use the different collimator angles for that. In our version of Eclipse 15.6, when we are going to the arc optimization process, so by default we are having the collimator angles of 30 degree and 330 degree. According to the vendor, it is helpful in because of these angles are because of the tongue and groove effect, and it is helpful for the extra dose spillage from the MLCs. But what we are doing, we are selecting the collimator angles for the head and neck, especially for the head and neck, with the 0 degree, one arc with a 0 degree, and another arc with the 90 degree angle. So we have compared both plans with the 30 degree and 330 degree collimators, and also with the 0 degree and the 90 degree collimator angles. So there was not so much significant difference between them. So if you are using the head and neck patient plan with the head and neck, and you have to feed with a VMAT and you are using the complete arcs, so avoid shoulders in the optimizations, because we have the x-axis, we cannot put the hands up for the patient setup, and shoulders are in between. So you have to avoid also the shoulders for that. So what would be the possible arrangements for the head and neck cancer, head and neck tumor of the VMAT if we are? It could be two full arcs, or it could be two full arcs above the shoulder and the partial arcs for the rest. We have to break the PTV, or you have the more than two partial can be used depending on the PTV size or location. This is the view of the three arcs which are be defined, like in picture A, two full arcs and the partial arcs. In the picture A, you can see that the two full arcs are used in the upper portion of the tumor, and at below where we have the shoulders, so partial arcs were introduced by avoiding the shoulders. Now, depending on the size of location, in the B picture, you can see we have introduced the two partial arcs depending on the shape of the PTV, or you can use the two full arcs again by avoiding the shoulder structure. After the selection contouring, then we have the selection of arcs. We have to switch to the optimization process. The first thing which we have to do in optimization process is to define the normal tissue objective. Normal tissue it can be defined automatically by setting the priority to 120, or you can set it to the manual with the priority 120 as shown in the picture, or distance from the target border with 0.3 centimeter, and the fall off and the dose should be around 60 to 105%, and also the fall off should be not more than 0.5. So let me say things that always set the priority where it should not exceed, where the PTV or OER priority should not exceed. So if you are using the PTV's priority for 100 or 110, or OER priority for till 100, so select the priority of NTO to more than the 100 or 110. Like in this picture, you can see the priority is of 120. After the NTO, then define the PTV lower limits and PTV upper limits. What we are doing, we are defining the two lower limits with 100% of the PTV received with the 100% of the dose, and the 95% for the 98% of the prescribed dose, and the upper limit for the maximum dose of 107% and 2% of the volume around the 105% dose. On the initial, we set the priority to 100. So always start with the optimization by defining the NTO and the PTV. Do not start the objectives for the OARs at the first stage. First, you have to run the optimization, and in between, you can introduce them by watching your DVF and that how your coverage is going on. Then after that, introduce a ring so that you can limitize the dose fall off, and introduce a ring of the maximum dose of 85% with a initial priority of 75. Always when you are introducing anything in between the optimization, so please pause the optimization algorithm for each small and large step in the optimization process, so that it will stop over there, and the MR level, which is defining the multi-resolution system, is level which is defining the Eclipse optimization. It will start from there, and you have a better coverage for that. Try to introduce one OAR at one time during optimization. Whatever are your practices, like add upper and mean objects according to the demand. We are using the priority 50 for initially, then on demand we move it to the 60 or 70 where we are seeing the coverage. So use the mean objectives of OAR that don't require a maximum dose constant. Push the OAR's priority until we can see the PTV shoulder begins to drop. It indicates that PTV OARs have reached their limits. So when you see that the PTV shoulder is going to drop, so kindly stop over there, increasing the priority of OAR. Repeat it for OARs and try to manage the shoulder again on the same position. Repeat your it for the OAR and for every small and large step until MR2 level is reached for the optimization process. This whole process of the optimization process and the contouring was inspired by the Mr. Adam Schulman. He described this process in the Reverse Contrast Center IMRT2 curriculum. It was a course which was done in the 2020-2021, in which he described the whole medical contouring by the AAPM 263 and then the optimization processes. So when you can see that you are happy with your plans, you are with the coverage, then you have to evaluate your plans. So the general criteria is the same, which we are always hearing from the UTCP and the NTCP. Although we are not using the same criteria by following a prescribing and the recording on the ICROD3, but this is the general evaluation. Next is to evaluate your target coverage, how much your target is receiving, with keeping in mind the OAR dose evaluation criteria by the difference if you're using contact or IMAMI or whatever the protocols you follow, or your physician is happy with that. Trying to meet the constant defined in optimization, like the spillage of dose, because when you're using inverse planning, so there are very much chance of a spillage of dose at the normal tissues. You have to look after on the slice where the pure PTV or the normal organs are defined, and also evaluate the beam fluence which is generated after optimization. Also, there are also those lines sounding the PTV, that how much coverage your PTV is getting and what is the maximum limit you're watching. Again, contouring is very much important for that. For this, we have to empower your doctors for this regarding the contourings, that they have to do their part perfectly. So when you are doing the optimize, you are making a structures, the OARs plus margins, so you have to be attentive. So while creating them, so if you are selecting any type of arc plans, so it will make a very decent plan. But for inverse optimization algorithm, you have to make a good plan by perfect contouring, by selection of good arcs. So we will have to a perfect one. Try to use the rings along with the NTO because they are very much useful for the controller dose spillage outside the PTV. Number of MUs are very much important when we are making a VMAT plan, because if we are considering the IMRT plan, so you can see there's a modulation factor, which is the modulation factor is the number of total MUs to the prescribed dose, which is prescribed by the physician. So in IMRT, if you are making head and neck plans, so it would be the modulation factor is around 6 to 7. But in the VMAT, according to our observation, it is around 4 to 5. Sometimes if we are very not so much tight constant, then the modulation factor is around 3 to 4. But normally we have the 4 to 5 of the modulation factor for the VMAT. So there's a significant decrement in this factor if you are switching from IMRT to VMAT. Now I will switch to the Eclipse, our Eclipse workstation, which is 15.6. Excuse us because if you can see the patient name or MR, so just consider this is the patient city of the patient, where we have the this is our PTV 5000 defined, which is for the phase 1. The prescribed dose is 200 CGY in 25 fractions. There's a list on the left of the screen. You can see this is a list in which these are some of the OARs and PTVs for the phase 1, phase 2, and phase 3, which were contoured by the physician. And then later on, there are a long list which was contoured by the medical physicist, termed as a medical physics contour. Like we have the H50H, we describe that I will highlight, hopefully you will understand it. The band which is introduced in the PT5050. Then we have the corners, which are also introduced for the optimization, which are on demand. Then we have some of like avoidance structures for that. If you are getting some extra doses in the normal tissue, you have to control the avoidance structures. And we have the rings, like for the phase 1, we have introduced the ring structure for the spillage dose should not, the dose fall off outside the PTV. And then we have the parotidic structures. Similarly, we have the contours for the phase 2 when we have the PTV 6600, and again the rings are made over here. And also you can see the edges are also in the list, and also the corners introduced for the PTV 66. Now I'm searching the external beam planning mode. This is a plan where by using the arc geometry tool, I have introduced the two arcs, two full arcs. Two full arcs were introduced. Initially, I defined just the NTU in this plan along with the priority of the PTV 5000 and maker and some isodoses were obtained after his optimization. Then in the next optimization, I introduced the OARs along with the simultaneously along with the ring structures, and other things were introduced in it. Further optimization was performed, keeping in mind the coverage of the PTV along with the OARs doses over here. This is the PT which is covered by the 95% of the acid dose, which is in the practice of us over here, the physicians. And this is the coverage along with the, let me close the ring first. The curve here, the blue line is a 50% acid dose lines. I have described that you have to avoid the shoulders also. So you have to make some structures, help structure for the shoulders. So what you can do, you can either block the introduce the constants for the shoulders by giving priority, or you can use the avoidance sectors for that, for shoulders. By defining avoidance sectors, you can off the flinch for that portion. And you can have the plan for that. Or other thing is that you can define the priority for the region by defining it. It will helpful that if you are defining a priority, so I would recommend you to define the priority for that, because otherwise the fluence for this portion will be blocked, the MLCs will be blocked, otherwise, and the other portion which is over above the shoulders will be open for the pain. So this was a phase 1 plan, which was made by using the rings, the edges, and all the contours which were defined. Similarly, we have the phase 2 plan. This is a phase 2 plan. Then we have the rings for that, also the structure for that. This is the first optimization for the phase 2, where we have not selected the full arcs. These are the arcs, the two arcs clockwise and counterclockwise, starting from the 275 till 165 degree, and then the same counterclockwise angle which was starting from the 165 to 275. It was selected this arc keeping in mind the position of keeping the PTV localization, the where PTV is located, and the shape of the PTV. Similarly, the same criteria was used for the optimization. Initially, only the NTU and PTU objectives were defined. Later on, the rings and the OARs were introduced in that. And in the end, the other structures like the hotspot and other things were introduced. Then we have the phase 3 plan for the PTV 70. We have again partial arcs for PTV 70 because it is placed on the right side of the patient neck. So same criteria was again used for PTV. So this is how we see the plans and then the physician approval. So what we do after the physician's approval, we send these plans to the portal dosimetry image verification, where these plans are run, and we have the portal dosimetry image before the patient treatment. If you have shoulders on the end, you have to also your shoulders, you have to avoid the shoulder, then we can again treat the patient with the 4-arc system, 4-arc beam arrangement, like 2 arcs for the upper neck and 2 partial arcs for the shoulder position. In this plan, you can see that this is the beam fluence. We have the arcs which were defined for the upper position, upper neck, and then we have the arc for the treating for upper neck and for the shoulder position, these partial arcs. So these are some of the arrangements which we are doing for the head and neck cancer. For portal dosimetry, once the plan has been finalized, we send our plan to the machine for the verification by the system. And these are the predicted dose, which we send the plan from our TPS, and this is the portal dose, and this is a combined verification. And there are some parameters which the system do it by itself, and or if there are some changes and we have some calibration units difference, so the plan will be failed. Otherwise, if you have a pass, so we can go ahead by making this approval. So this was the VMAT optimization method which we are using over here in AKUH, depending on the method introduced by the Mr. Schulman in the RCC IMRT session. So that was by my side. So if you have any questions or suggestions, so please come forward for that.
Yes, sir.
Mr. Nazar,
Sir.
kindly unmute them so that if anyone want to ask a question.
Okay, sir. Okay, I have unmuted the participants if they have to ask any question. There is a question in the chat box. Kindly show the plan of head and neck again.
Khurram, which plan you want to see? The phase 1, phase 2, phase 3?
Sir, are you are not doing SIB, or you are doing phases?
We are doing SIB, but it is for only for we have done some cases for the pelvis region, but for head and neck, I don't think that we have done any patient, 1 or 2 patients for that, also for the head and neck also, if I'm not wrong.
Okay, kindly show me the phase 1, like the beam arrangements. I want to review it.
Khurram, this is the phase 1. Can you see?
Yes.
So this is phase 1 plan with PTV 5000.
In your previous slides, like you were showing the 2 arcs, 2 partial arcs, and 2 arcs with partial 1, 2, 3. There were 3 pictures before optimization. I have a question that how you are going to plan head and neck having shoulders also, like nasopharynx patient from eyes. The PTV starts from the eyes till supraclef. We have to treat how you are treating it using a 2 isocentered techniques, or having
Khurram?
1 iso. Yes, this one. Yes.
Yeah, this is a patient. Here you can see that the tumor is in between the eyes also. So we have used the four different arcs, like the two complete arcs. If you can see the fluence also. So there is a fluence. So where we have defined the constants for we have the partial arcs also for the upper portion, which were defined over here. You can see the projection of the arcs over here. And then we have the complete arcs for the lower portion also. So for that region, we have divided the PTV into two portions for this optimization.
Nancy.
Sorry. Yes, so we have divided the PTV into two portions. For upper portion, we have the different arc arrangement, and for lower portion, we have the different arc arrangements.
Then how you are arranging the arcs having one isocenter with two different PTVs? Like there is an option like having one PTV
the same,
and,
PTV is the
and
same.
with
We have the same PTV. What you can do, you can also optimize it by defining the arcs over there, or you can break it by yourself for that portion. And by giving the priority to both the regions, you can plan the patient regarding it.
if the same plan is planned with one isocenter, with two isocenter, two full arcs, is there any difference? Like here it is used four arcs, like two full rotations and two half rotations with one isocenter.
You can plan with a single arc, you can plan with a different arcs. So it is depending on the experience how you're going to cover the PTV also, because you have the freedom of selecting the arcs with the different angles. So if we can introduce more arcs, so you are giving the freedom to also the algorithm for generating the fluence. So it will be helpful in regarding the coverage also and regarding the OARs.
Okay, thank you.
Welcome.
Hello, Zaeem. Hello.
Yes.
Yeah, can you hear me?
Yes.
Yeah, my question is regarding the algorithms. Which one you are using for the VMAT?
We are using the AKUH.
AKUH, yeah. So before implementing the AKUH on a clinical implementation, before its clinical implementation, have you done the one-to-one testing? Because I know these kind of algorithms sometimes underdosing, underestimating the doses, especially you can see even in this typical case where there are air cavities, how the system is behaving before its clinical implementation. What kind of tests have you done?
Yes, we have performed the end-to-end testing for the AKUH, and also though I have shown like we are doing the PDIP for the patients.
You know, relying on portal dosimetry is another challenge because the vendor is given by the vendor and
Yes,
doing
I
the
agree
same.
with you. I agree with you. But right now we have the photo dosimetry options only for that for verification. So when you have another tool, so I agree with you. Hopefully we have the another tool for that verification also.
I think point one-to-one measurements, specifically point dose measurements using independent calibrated chambers and the film dosimetry. I mean, have you done those kind of verifications before?
Yes.
Before relying on the portal dosimetry?
Yes, we have done.
All right. So the algorithm is doing a good job where there's the cavities. Are you happy with?
Sometimes you can say that because when we have a high density material introduced, so we cannot make the physician happy for that. So on our side, we can say that we are a little bit happy for using the AKUH.
So even in your phase one, I can see there where there's a cavities, there's a lot of breakdown in the 95 and it is directly affecting your DVH. So if you are not achieving those constants, how you are satisfying the physician?
What we are doing, like we are the subtracting the P2E structure. Sometimes what we do, we subtract the P2E structure from that artifact. so that our DVS should not be affected by that artifact. But you can do it by subtracting the PTV from that artifact, like defining another tumor, another objective.
No, that's fine. My point is, if you look at the transversal view now, which is displaying on your screen, you can see there's a small breakdown. There's a breakdown of 95. Well, yeah, you can see those breakdowns, which is the part of the PTV. But the
Yes.
system is not doing a good job in terms
Yes.
of the coverage there, and that's affecting your DVH ultimately. So, are you explaining this to the physicians, or you are just saying that it's the background breakdown
Yes.
is?
Physician ask about that, the why our coverage drops, so we can explain them, or you can also define by introducing some of the helping the structures and defining them the priorities. So we can try over there if physicians are not happy with this plan.
All right. So secondly, when you crop your PTV from the body, especially if it's reaching, if you don't want to use the bolus, at the same time, they want to, the surface coverage. That's becoming very difficult for the optimizer because of the built-up region. So in that case, do you have any limit to crop your PTV from the body, or you are just, if the physician don't want to use the bolus, what's the scenario there?
Yes, if physician bolus is placed with the, you can say the approval of a physician. So if not, so we crop the PTV from the body with the 3 millimeter margins.
Yeah. All right. Thank you.
Welcome.
Sir, we have a question from a participant in the chat box. In IMRT, how many margins are given except GTV?
Kindly elaborate this question. In IMRT, how many margins are given?
I think how much maybe, maybe from the GTV, it's like
Margins for what?
From GTV.
Kindly ask that question again so that it be clear for me to answer. Okay, any other question except that?
Hello, Assalamu alaikum, Zaeem bhai.
Walaikum Assalam.
Zaeem bhai, this is Sharib Ahmed. Just want to ask, did you try some biological optimization for head and neck
No,
in Eclipse
we don't have lessons for that and we haven't tried it.
for upper GUD, lower GUD, anything
Yes,
like
we
this?
have tried the GUDs. We have tried GUDs, but not so much plans have been done. So right now we are just focusing on the basic of priority defined. We have used GUDs, but you can say occasionally.
Okay. Because as per our experience, for the serial structure, GUD works very well.
Yes, I agree with you, and we have experienced the same thing. But we will try to shift to GUD as much as we can.
Sir, there is a question in the chat box. How much coverage can be compromised when restricting those two organs involved in PTV?
It depends that how is your physician, how much tolerance he has to accept the PTV coverage. To be honest, nothing good answer I can say except this, because if your physician is like he wants a total 100% coverage and along with the organs which are involved in that, so you can't do that. Sorry to say. For if you have the PTV and the OARs merged in each other, so you have, and you at the same time you want your organs to be limited and your PTV with the coverage. So I don't think it is possible. Then you have to create the VMAT structure, VMAT PTV structure by subtracting the OAR and optimize on it.
Okay, sir, that's all from the chat box question. If anyone has to ask any question verbally, they can ask.
Zain, how much margin, yeah, PTV, how much margin you crop PTV from the body? Like is the body and PTV is overlap and PTV is outside the body? And
Yes.
what's your procedures or what steps you are applying?
Normally it's not so much hard and fast. So normally we are using 3 millimeter margins for that.
Okay, sir, we have another question. Do you contour crop organs involved in PTV and then apply objectives, or just apply constraints on the minus structures?
You can use both. If you are using the contours which are the crop organs, you can define objectives also on that, and also on the VMAT. It will help in your optimization. So it would easier for the algorithm to during the optimization. So you can use both. We are using both options which are available.
Assalamu alaikum, sir. Zaeem, can you hear me?
Walaikum salam.
It's Mosman Nepal here. Sir, I would like to ask how you can improve the dose homogeneity in VMAT plan.
Mohsen, would you like to repeat your question? Because your voice is not so much clear.
I'm asking, sir, how can we improve the dose homogeneity in VMAT plan?
Mohsen, what I have experienced that if you have proper constraints defined, and if you have the proper arc selection, then you have if you have multiple arcs, like if you're planning a head patient, then you will not acquire a good homogeneity between the PT. But if you have multiple arcs, you will get the dose homogeneity. Otherwise, if you have not so much good dose homogeneity, so you can define the structures in it, like the other which were included in my slide in the other contours. So it would helpful in bringing the dose homogeneity in it.
There's another question. Are you controlling gantry modulation or just let it go? Because PDIP sometimes does not incorporate it very well.
Sharif, you are asking it for only for PDIP? Well, Sharif, if you're asking for PDIP, no, we are not controlling gantry modulation. It's just on the same position. And you can say it's just let it go style.
Okay, thank you, Sir Zaeem, for such an informative session. I guess that's it from the participant question. If anyone has to ask, they can ask, or we will wind up the session.
Okay, thank you, Naza.
Thank you everyone for joining. Inshallah, tomorrow we will join with the 4th lecture on multi-criteria optimizer, and see you all tomorrow. Thank you.